So moving on to the next type of nephrotic syndrome, which is focal segmental glomurulosclerosis. So this is going to be the most common nephrotic syndrome overall, and also this is the most common nephrotic syndrome seen in adults. So there are various causes of this FSGS, including genetic and acquired causes. So under acquired causes, we'll see that it's commonly due to idiopathic causes, that is no causes known. Other than that, any kind of cause in which leads to decrease in the renal tissue, so that will result in FSGS, because the FSGS itself means sclerosis. Sclerosis means there is going to be shrinkage and fibrosis, so there is going to be loss of the renal tissue. So all of the causes which are again causing loss of renal tissue can trigger FSGS kind of pattern. So examples like renal ablation, then you'll have congenitally also they are having renal agenesis, or reflex nephropathy resulting in decrease of renal tissue, or IgA nephropathy which can result in scarring. So along with that, heroin addiction, HIV, you remember HIV, heroin addiction, sickle cell diseases, then hypertension. So all of these causes are acquired causes of FSGS. So again, the causes are going to be very, very important. While inherited causes, we have certain mutations in the proteins involved in the formation of the filtration membrane. So here we have some many proteins involved in the formation of filtration membrane. So only the important one I'll be telling here. So NPHS1 gene, which codes for the nephrin protein, is going to be mutated in congenital nephrotic syndrome of the Finnish type. While the NPHS2 gene, which encodes the podosin protein, is going to cause steroid-resistant nephrotic syndrome and also autosomal recessive FSGS. Then alpha-actinin 4 protein, if that is getting mutated, it will result in autosomal dominant FSGS. While TRPC6, which is a calcium channel, it is going to be mutated in adult onset FSGS. So all of these are can be asked as MCQs. And like I mentioned, it's a nephrotic syndrome. It is going to present with a non-selective proteinuria. Massive proteinuria will be present. And here there is a gene called as apolipoprotein 1 gene, and that is also associated with FSGS. We have many variants of this FSGS. So we have a glomerular tip variant, which is going to have the best prognosis out of all, while there is a collapsing variant which has the worst prognosis. And this collapsing variant is important because this is the one which is associated with HIV, and HIV-associated nephropathy is called as HIVAN. So HIVAN is HIV-associated nephropathy. It is nothing but collapsing type of FSGS. Okay. And here again, FSGS can recur in 25 to 50% of transplant in the transplanted kidney also. So what are the features we see in FSGS is that, as the name suggests, it is going to be focal. Focal in the sense, it is just the opposite of diffuse. Suppose you have 10 glomerulus. So all 10 glomerulus are involved, then it is called as a diffuse process. While if only some 3 or 4 of the glomerulus out of the 10 is involved, it is called as focal. So only some glomeruli will be involved in FSGS. And segmental. Segmental means a part of the glomerulus. Suppose I am telling this 5 glomerulus are being involved. So out of this 5 glomerulus also, only a part of the glomerulus, not the entire glomerulus, is going to be involved. So in this example also, if you see, this is the entire glomerulus, but only this part of the glomerulus is being involved. This is all being normal, right? So this part of glomerulus being involved is called as segmental involvement, while the opposite of that will be a global sclerosis. So global involvement is entire glomerulus is being involved. So in FSGS, you are going to see a few glomerulus only are going to be involved by sclerosis, and out of this few also only part of the glomerulus is going to be involved by the sclerosis. Sclerosis is nothing but there will be deposition of collagen. So when this deposition of sclerosis is there, it will automatically obliterate the capillary lumen in the glomerular tufts. So capillaries will collapse. So this is also a feature of FSGS. So FSGS, you can have on immunofluorescence any kind of immunoglobulins and C3's deposition in the sclerotic areas. And on electron microscopy, like a minimal change disease, here also you can see diffuse effacement of the food processes. So if you appreciate here, so hardly the food process, it should have been like this, right? So hardly we are able to see any food processes here. So it is all flattened like this. So this is all the food processes which are flattened and effaced. So this is diffuse effacement of the food processes. Along with the food process, damage can be seen in FSGS. So seeing about the specific type of FSGS, which is collapsing FSGS, which is associated with HIVAN. That is here the most important feature of HIVAN will be on electron microscopy. You are going to see tubulo-reticular inclusions in the endothelium. So in this image, if you see this part, it is appearing like this, right? Something is being like this. So this kind of an image can be given, and that represents the tubular reticular inclusions in the endothelium only, and this is associated with HIVAN. So on light microscopy, how does this collapsing FSGS appear? So this part is the glomerulus tuft actually. So this is entire glomerulus, but the tuft has come to in between. So this is actually a silver stain. So only in the center the glomerulus is there. It is all kind of collapsed, right? Because of the cellularity seen here. So you see lots of cells are filling this gap of the Bowman space. So between the parietal and parietal and visceral epithelial layer, you have lots of cellularity, and this cellularity is actually because of the proliferation of the visceral epithelial cells. Okay, remember in crescents it was proliferation of the parietal epithelial cells. In collapsing FSGS, it is going to be proliferation of the visceral epithelial cells. So proliferation of this visceral epithelial cells is there, which is filling up this Bowman space and compressing and collapsing this glomeruli. Okay, so retraction and collapse of the glomerular tuft along with this visceral epithelial cell proliferation is the classical feature of a collapsing FSGS. Then we'll see about fibronectin kind of glomerular nephropathy. Here it is an autosomal dominant kind of disease. Here there are two forms of fibronectin usually. So a plasma derived form and a cellular derived form. So under the cellular form, it is going to be produced by the mesangial cells, and under plasma cells, plasma form of fibronectin is going to be derived from the liver cells. So this plasma kind of form is going to be the pathogenic form involved in fibronectin glomerulonephritis. It is also going to present with a nephrotic kind of syndrome, and deposition and the proliferation will be here that of a mesangium. So fibronectin, anything related to fibronectin, there will be mesangial proliferation along with mesangial deposits, whereas there will be no immunoglobulin or complement deposits on immunofluorescence. So this remember this mesangial proliferation and deposits for fibronectin, and the pathogenic form will be the plasma fibronectin.